Assalamu alaikum. Good evening everyone, it's Donia and today I'm talking about common orthopedic lesions. This video will be in English only for the sake of any student who cannot cope with Arabic language. So for common orthopedic lesions, we have four main subtypes. Number one, bone-forming tumors, fibrous lesions, cartilaginous lesions, and finally cystic lesions. We also have malignant bone tumors. I'll discuss this in another video. Starting with bone-forming tumors, we have three main bone-forming tumors: osteoid osteomas, osteoblastoma, and osteoma, and they are usually benign. Starting with osteoid osteoma, this name contains two O. That's to memorize us or remind us with the fact that this tumor is characterized with a certain feature of pain. This pain is increasing at night, and however it's relieved by aspirin. So the pain is severe at night, yet it's mildly relieved by aspirin. The pain usually annoys the patient, and the patient will ask the help of three doctors. Three doctors to remind us with three Ds, three main information starting with letter D. Number one, diaphysis of the femur or tibia, which is the common site of the osteoid osteoma, and then the bone scan is usually characterized with double dynasty sign. So this is our table. We are talking about osteoid osteoma, which is usually at the diaphysis of the femur or tibia. The patient is usually a male, younger than 30 years old, with characteristic pain being increased at night and relieved by aspirin. The CT includes osteolytic nidus, which is a radiolucent nidus less than 2 cm, and the bone scan is characterized with double dynasty sign. And this is an image of the osteolytic nidus. In the osteolytic nidus, it's usually surrounded by sclerotic bone or cortical thickening, and it could be calcified if it occurred at the talus, calcaneus, or even the pedicle of the vertebra. Now let's move to the osteoblastoma. Osteoblastoma contains letter B, which refers to two important informations also with the letter B. For osteoblastoma, it affects the posterior column of the spine, and this usually results in spasm of the back muscles, so have BPB. The lesions are usually well demarcated osteolytic lesions, as you can see here, and osteoblastoma is also referred to as giant osteoid tumor because it's very similar to the osteoid osteoma but a little bit bigger. So this time the osteoblastoma is also radiolucent osteolytic lesion, yet it's more than 2 cm and it contains reflex of calcification. The bone scan has intense activity. As expected, it's a giant osteoid tumor. All of these are just memory aids. The last bone-forming tumor is the osteoma, and osteoma prefers to affect the skull. This is the most common site. It usually affects the skull, and as you can see here, the skull is the most commonly affected site, and the CT will show dense bony swellings. It can also affect the mandible. Now let's move to the fibrous lesions. In the fibrous lesions, we have also three main lesions. Number one, fibrous cortical defect, non-ossifying fibroma, and fibrous dysplasia. Fibrous cortical defect, as its name implies, it occurs in the cortex. It's well defined, usually lytic, and the margins scalloped or sclerosed. We don't have to go through much details in fibrous cortical defect in undergraduate level, as non-ossifying fibroma is more important. First of all, whenever we would mention the word fibroma, then this lesion is usually a geographic lesion. This is because I'd like to remind you, in chondromyxoid fibroma, we have mentioned the word fibroma, so the lesion will also geographic. As you can see here, it's non-ossifying, which means that it's not formed of bone, or it doesn't result in bone formation, so it's a bubble-like lesion, multilocular, single or multiple bubble-like areas with no bone formation inside. So that's what's meant by non-ossifying fibroma. It's usually intercortical, and the borders are also well defined, yet they have festinating borders. Finally, we have fibrous dysplasia. Dysplasia is an important keyword. It starts with letter D to remind us that in fibrous dysplasia we have a common deformity, and this deformity usually occurs in the diaphysis. So fibrous dysplasia results in Shepherd-Krug deformity, which usually affects patients aged 5 to 30 years old, and it usually occurs in the diaphysis of proximal femur. On CT finding is ground glass appearance, as this image is trying to remind us. This is strep crook deformity, and as you can see here, the proximal femur is affected. Now let's move to cartilaginous lesions. We have four main lesions: in chondroma, chondroblastoma, chondromyxoid fibroma, and finally osteochondroma. Starting with in chondroma, because it is the most common interosseous cartilaginous tumor, and this information is very important because it commonly comes in MCQs. Most commonly affected bones are small tubular bones of hands and feet. The margin is usually scalloped, lesions are solitary, and there is usually associated calcification. For chondroblastoma, let's first talk about this memory aid. Any lesion starting with the word chondro is usually affecting the epiphysis, because this lesion is usually affecting the cartilage, and the cartilage is usually located in the epiphysis. So chondroblastoma is eccentric in the epiphysis or across the crossplate, usually calcified 50% central calcification, and there is usually linear periosteal reaction representing also 50%. The bone scan will show increased uptake at the margin. For chondromyxoid fibroma, it also starts with chondro, so it usually affects the epiphysis, eccentric in the epiphysis or across the crossplate. And as we have said, the word fibroma would remind us that this lesion is usually geographic. Concerning chondromyxoid, letter X will remind us with three main information starting with S: scalloped margin, sharply outlined, sclerotic edge. So letter X refers to three main information starting with letter S. Finally, osteochondroma. Osteochondroma usually affects patients with multiple achalasia or dwarfism. So it's very important to follow a patient's multiple achalasia and dwarfisms to exclude osteochondroma if they have any bony complaints or any bony swelling. This lesion is usually polystotic, which affects multiple bone sites, and the CT will show extosis, well-defined lesions growing away from the physis. Now let's discuss what's meant by extosis. Extosis means that this tumor is non-cancerous. Multiple bony swellings, yet they are non-cancerous. Finally, let's discuss cystic lesions. We have two main cystic lesions: simple bone cysts. Simple bone cysts, we have to remind ourselves with simple bone cyst as an ice cube that falls on the ground and crashed into smaller pieces. Why? First of all, ice cube, because it would remind us that this bone scan is the first bone scan to talk about in our presentation to be called bone scan, unless there is bone fracture. And this ice cube, when if fall on the ground, it will be fragmented. This is to remind us with the falling fragment sign that's present in CT, as you can see here. And as we all know, ice cubes are usually radiolucent, so ice cube will remind us with all of the information we need. This is the diaphysis of the crossplate, which is usually the most commonly affected site. Again, there is cystic radiolucency with pseudo-loculated appearance, some loculations, but this is not complete. And this is a falling fragment sign we have been talking about. The bone scan will usually be called unless there is bone fracture. Lastly, we have aneurysmal bone cyst. It's usually eccentric, but it doesn't extend to the joint. Most importantly, the bone scan will be opposite to simple bone cyst. It's usually warm to hot, and the most characteristic lesion is cross honeycomb lesion affecting the bone. And as you can see here in the CT, usually the width is larger than the length. So now we have summarized our common orthopedic lesions, and see you in another video talking about the malignant bone tumors. Thank you so much.